This single line on the monitor just told me my patient was about to crash, and most nurses would have missed it completely. What you're looking at right now is an arterial pressure waveform, and in the next 15 minutes, I'm going to show you exactly how to read these life-saving signals, manage arterial lines like a pro, and avoid the deadly mistakes that 90% of new ICU nurses make. Hey everyone, welcome back to NurseBrain. I am Neil Brian Galvin. If you're new here, this channel is all about giving you the confidence to succeed in critical care by breaking down complex topics and making them easy to understand. Now, here's the thing about arterial lines. They're everywhere in the ICU, but most nursing schools barely touch on them. You walk into your first ICU shift, and suddenly you're expected to know how to zero a transducer, interpret waveforms, and draw blood samples without contaminating the line. Sound familiar? But here's what nobody tells you. Mastering arterial lines isn't just about following protocols. It's about understanding the why behind every step. Because when you truly understand arterial lines, you become the nurse who catches problems before they become emergencies. So, in this video, I am going to give you everything you need to know about arterial lines. We'll cover the setup, monitoring, troubleshooting, and I'll share some insider tips that took me years to learn. Plus, I'll show you the 3 most common mistakes that can literally kill your patient and how to avoid them. Alright, let's start with the basics. An arterial line, or A line as we call it, is a small catheter inserted directly into an artery. Now, most commonly, we use the radial artery right here in the wrist, but we can also use the ulnar, brachial, femoral, or dorsalis pedis arteries. But here's the critical part that everyone needs to understand. Arteries are your body's highway for oxygenated blood. So before we ever inserted an arterial line, we must ensure there's collateral circulation. This is why we do the Allen's test for radial artery cannulation. Watch this. We compress both the radial and ulnar arteries. Have the patient make a fist to drain the blood. Then, release the ulnar artery. See how the hand pinks up? That's collateral circulation, and it's literally the difference between a successful procedure and a potential limb loss. Now, arterial lines serve 2 main purposes: continuous blood pressure monitoring and easy access for blood sampling. But here's what makes them so powerful. They give us real-time beat-to-beat pressure readings that no cuff can match. Now, let's talk about setting up your arterial line system, because this is where most errors happen. And trust me, I've seen what happens when this goes wrong. First, your transducer system. This is your lifeline to accurate readings. You need your 500 ml bag of normal saline, and here's tip number 1 that nobody teaches you. Always use 0.9% of sodium chloride. Never use dextrose solutions or any other fluid. Why? Because you're going to be drawing blood samples from this line, and you don't want to contaminate your lab values. Next, your pressure bag needs to be inflated to 300 millimeters of mercury. Not 250, not 350, exactly 300. This pressure needs to be higher than your patient's systolic pressure to prevent backflow of blood into the tubing. Here's something critical. Your arterial lines should be clearly labeled and easily distinguishable from IV lines. I've seen nurses accidentally push medications into arterial lines, and let me tell you, that's a career-ending mistake that can cost your patient their limb or their life. This continuous flush rate should be 3 to 4 ml per hour. This keeps the line patent and prevents clot formation. And here's a pro tip. Never ever discontinue this flush. I don't care what's happening. That flush stays on. Now, we get to the really exciting part. Actually, monitoring your patient. And this is where you separate the good nurses from the great ones. Your transducer needs to be labeled to the phlebostatic axis. That's the fourth intercostal space at the mid-axillary line. Think of it as the level of your patient's heart. If your transducer is too low, you get the falsely high readings. Too high, and you'll get falsely low readings. But here's the game changer: learning to read arterial waveforms. Look at this normal waveform. See that sharp upstroke? That's systole. The dichrotic notch here? That's your aortic valve closing. This waveform tells a story about your patient's cardiac function, vascular resistance, and volume status. Now, let me show you what problems look like. This overdamped waveform, see how it's flattened? This could be air bubbles, clots, or kinked tubing. Your blood pressure readings will be falsely low and you might miss a hypertensive crisis. This overdamped waveform, with all these oscillations, this overestimates your systolic pressure. You might think your patient is hypertensive when they're actually normal. Here's the critical skill. You need to zero your transducer at least once per shift. And whenever you question the accuracy, zeroing eliminates atmospheric pressure interference. It takes 30 seconds and can save your patient's life. Let's talk about drawing blood from arterial lines, because this is where contamination happens, and contaminated samples lead to wrong diagnosis and wrong treatments. First rule: only draw blood when clinically indicated. Don't just draw because you can. Every time you access that line, you're introducing infection risk. Here's the technique that most people get wrong. You need to withdraw and discard 3 times the dead space volume of your arterial line. For most systems, that's about 5 to 6 ml. This eliminates contamination from the flush solution. Watch my technique here. I'm using strict aseptic technique. I'm withdrawing my discard volume, then drawing my sample. After sampling, I flush thoroughly but gently. Never force a flush. If there's resistance, there might be a clot, and forcing it could cause an embolism. Pro tip for blood gases: get that sample on ice immediately. If it's going to be more than 10 minutes before analysis, temperature affects your pH and gas values. Now, let's talk about the complications that keep me up at night, because these are the ones that can seriously harm your patient. Infection is always a risk with any invasive lines. Watch your redness, swelling, and drainage at the insertion site. Change dressing accordingly to your facility policy, usually every 7 days with transparent dressings. Thrombosis is another big one. Always assess distal circulation. Check that radial pulse. Look at capillary refill. Assess skin color and temperature. If you see any signs of compromised circulation, notify the physician immediately. But here's the complication that terrifies me most: accidental drug injection into the arterial line. I've seen nurses accidentally connect IV medications to arterial lines. The result? Arterial spasm, thrombosis, and potential limb loss. This is why clear labeling and following your 5 rights of medication administration is absolutely critical. Air embolism is another serious risk. Always ensure your system is properly primed and free of air bubbles, and never, ever inject air into an arterial line. When it's time to remove an arterial line, this isn't just pulling out a catheter. You need to check your patient's coagulation status first. If they have abnormal clotting, discuss with the physician before removal. After removal, apply direct pressure for at least 10 to 15 minutes, longer if the patient has coagulation issues. I've seen nurses apply pressure for 2 minutes and walk away, only to find a massive hematoma later. Here are some advanced tips that will make you stand out. Learn to correlate your arterial line pressures with clinical assessment. If the numbers don't match what you're seeing clinically, trust your assessment and investigate. Understand that mean arterial pressure is often more reliable than systolic pressure for comparison with cuff pressures. The map is what perfuses your organs. And here's something most nurses don't know: arterial line pressures can be affected by patient positioning, especially with femoral lines. Always consider position when interpreting values. Alright, let's wrap this up. Arterial lines are incredible tools that give us real-time insight into our patient's cardiovascular status, but with great power comes great responsibility. Remember the key points: ensure collateral circulation before insertion, maintain that 300 millimeters of mercury pressure bag level, and zero your transducer properly. Interpret those waveforms, use sterile technique for blood sampling, and always assess distal circulation. Most importantly, never forget that behind every arterial line is a patient who's trusting you with their life. These skills aren't just about passing your orientation, they're about being the nurse who makes the difference between a good outcome and a tragedy. If this video helped you understand arterial lines better, smash that like button and subscribe for more critical care content. And hey, if you're studying for CCRN or just want to level up your ICU skills, check out this video on hemodynamic monitoring. It's the perfect next step in your critical care journey. Drop a comment below and let me know what's your biggest challenge with arterial lines. I read every comment and love helping you guys succeed. Until next time, keep learning, keep growing, and remember, you've got this. Once again, this is NurseBrain, inspiring greatness one lesson at a time.